Dr. Asit Arora, Dr. Giriraj Vora, Dr. Arindom Ghosh. So now I'm handing over the session on to our respected chairpersons.
So this will be basically on liver section. There will be a little bit change in the order of presentation. The first presentation will be by Dr. Tiyagrajan, who will be presenting a video on robotic donor hepatectomy. Dr. Tiyagrajan, please.
Greetings from Chennai. Thank you, Dr. Ajay Mandal, Sanjoy Mandal, and IASGCON. Today I'll be showing two videos. They gave me a topic of robotic donor hepatectomy. So I just wanted to give the perspective of both laparoscopic and robotic hepatectomy. First I'll play a short video on laparoscopic, then I'll play a short video on robotic donor hepatectomy. See, this is how the incision looks like. It has evolved over 3 decades. Now at least 10% or 15% are done by minimally invasive. So in laparoscopic, we use 3D laparoscopic, flexible, 5 ports, 1 epigastric, 1 anterior axillary, 1 umbilical for camera, and 2 midclavicular. This is my case, 28-year-old male. You need to have a good graft to remnant weight ratio of 0.8 at least, and a good remnant more than 32%. So this is preferable to have single right biliovascular pedicle. This is a single right hepatic artery, single right portal vein, single right hepatic duct. This is the MHV, which is very tricky in laparoscopic and robotics. You need to plan the veins retrieval well in advance. This patient had a good fissural vein, so we plan to take a good remnant, subtotal MHV. So first we divide the falciform ligament, go to the space above the right hepatic vein. You create a space between the right and the middle hepatic vein. Then we divide the triangular and coronary ligaments. You have to be very careful in retracting the liver with atraumatic graspers, because it can injure the liver. The flexible endo-eye view gives a very good advantage over normal laparoscopy in the corners of the liver. And you leave the topmost portion for later. Once you've done the right lobe mobilization, then we go on to the anterior caval dissection. There are around 5 to 12 caudate veins which directly drain from the caudate into the IVC. And you go from the caudal to cranial approach, which is different from open, but you get both in laparoscopy and robotic view, excellent view, which it's not possible by manual vision. And each of these small veins are carefully dissected. This is a right angle dissector in action. It gives a good dissection plane for these veins. You have to be very careful, because once these veins bleed, they bleed torrentially. And you don't have to panic. You have to just apply gauze piece and apply and handle it slowly. If you panic, the IVC rent increases. Then you clip them, and if there are little big veins, you can suture them. And around 60% of the cava is mobilized from the caudate, and the assistant holds the caudate to give a better vision. You don't address the hepatocaval ligament in the earlier stages of anterior caval dissection. You leave it for later. And now you create, after dissecting the caudate, a space is created between the right and the middle hepatic vein, and you pass a catheter. It comes out through the previously created space from the above. So this is how this is the wide angle dissector. This is how we pass the catheter. Then we move on to porta dissection. You do the cholecystectomy, but don't remove the gallbladder. It helps in retraction. The assistant holds the bile duct. You directly go to the peritoneal attachments over the right portal vein, and you isolate the right portal vein. And usually there are 1 to 2 caudate veins which drain directly from the caudate into the right portal vein. You have to be very careful, and you can dissect them out and clip them and divide them. This is the caudate veins. Then once you loop the right portal vein, you go address the right hepatic artery. So this is the wide angle dissector in action. It helps you to loop the portal vein, and you need to have these instruments in your armamentarium. And you can do a lot of dissections with the harmonic itself without using the energy. And it's very important you have to be similar in approaching in laparoscopy as in donor hepatectomy. Tissues away from the right hepatic artery, you can do energy source, but very close to the right hepatic artery, you cannot use the energy source. You have to use the scissors because the thermal injury to the artery can be very catastrophic. Once you loop the right hepatic artery, then you mark the confluence of the bile duct. Then you apply 2 laparoscopic bulldog clamps in the right portal vein and the right hepatic artery. You get a nice transection line. And you start the transection, mark the transection between the space from the right and middle hepatic vein to the biliary confluence. And you can see the transection line. The assistant holds the lever to aid in this procedure. The first 1 or 2 centimeters of the lever is transected primarily by the harmonic. And we use an interesting technique, a rubber band technique or the proline. You suture this and you hold it out through a separate needle from the abdomen. The assistant holds in it. It avoids a port. And this is the harmonic in action. Then use laparoscopic Cusa. You dissect out the veins. This is the segment 4B vein, which is hemolocked and divided. And it's important that you, in the donor surgery, you carefully dissect out the pedicles, because when you use a lot of energy source in the pedicles, they can leak. You have to clip them and divide them, even if you are doing by other techniques other than Cusa. Then you go along the left border of the middle hepatic vein, and you have to identify the segment 8 vein. Once it joins, this is the segment 8 vein and the middle hepatic vein, you isolate. In the hybrid procedure, from this we convert into an open procedure where the last part of the caudate transection is done by open technique. It preserves both the advantages of a minimally invasive and a safe donor hepatectomy. The graft is retrieved through a small midline incision, and you have a very low cold ischemia time. This is the incision you get. In robotic, so this is a 26-year-old female who donated her right lobe to her father. The right lobe volume was good, 0.98 GRWR. The remnant was good, 38%. And then we look at the imaging. It is important to have a clear-cut plan before the surgery, how we are going to address the This is the right portal vein. You can see in 3D simulation, and this is the right and left hepatic veins. And it is important the middle hepatic vein. You divide the segment 5 and 8 in this case. This is a modified right lobe. This is the right hepatic artery. Here the segment 4 artery is from the left lobe. This is the single right hepatic duct, and this is the simulated. And we use 4 ports for robotic. We help with laparoscopy for the CUSAs if you want to, or the staplers and the suction. And first you divide the falciform ligament similar to the laparoscopy. And the advantage with robotics is you have more degrees of freedom, where it's not that rigid like laparoscopy, and the suturing is much easier, and the learning curve is smaller. But I don't think each procedure is exclusive. They are complementary to each other. Robotic, laparoscopy. We can do hybrid robotic and laparoscopic. You can use a laparoscopic CUSA in a robotic donor hepatectomy. First, we address the right hepatic artery, and you carefully dissect out the right hepatic artery, and you isolate with the vessel loop. Then you go to the right portal vein, and you dissect the right portal vein, and the assistant holds the bile duct above. And it's important that the liver is held in good traction position by the forceps. Once they are looped, we go to the right lobe mobilization. It's a matter of choice. You can either do porta first and mobilization, or a mobilization and the porta. After mobilizing, you go to the anterior cava, and you divide these caudate veins, and you create a space again like a laparoscopy between the right and the middle hepatic vein. Sometimes you can divide the caudate. It aids in the transection and the later looping of the bile duct. You apply the bulldogs in the artery and the portal vein. You get a nice transection line. One advantage with robotic is you will have an inbuilt ICG camera where you can ask an anesthetist to give the ICG once you are clamped, and it clearly shows a transection line. But in laparoscopy, you will have to have a separate ICG camera. So that is another advantage of robotics. So here we mark the transection line from the space between the right and middle hepatic vein and the biliary confluence. You have to exactly mark the biliary confluence, and you remove the bulldogs. You can start the transection. The transection technique is a little different in the robotic and the laparoscopic because you don't have a robotic CUSA. Either you can do a hybrid laparoscopic CUSA in the robotic. That's not very logistically easy. Or we have a combined technique of using a harmonic for the earlier parts. Then you like a small biting thing, small levels of tissues are done away with both the bipolar forceps and the harmonic. And you carefully isolate the pedicles and the veins.
You need to slightly speed up.
So it's going to close.
Yeah, time's up.
And the right hepatic duct, then you isolate, and you apply a clip applicator on the right side, and you divide the right hepatic duct with a scissor, not with an energy source. This is the right hepatic duct. And you can, ICG camera can aid in the identification of the right hepatic duct. Duct division is the Achilles heel of minimally invasive donor hepatectomy. Once you divide the right hepatic duct, then you apply the bag, liver in the bag. You're ready for retrieval. And you apply bulldog clamps to the hepatic artery. You suture the right hepatic duct. So after dividing, you go to the right hepatic vein, you loop it and do stapling. This is a Covidian stapler which we use, tri-stapler cartridge. This is the right hepatic artery you're dividing with a scissor. And this is the right portal vein. You apply with the tri-stapler cartridge, you divide. Then you go to the right hepatic vein after dividing the right portal vein. Now this is ready for retrieval. You retrieve it through a fan and steel incision. And that completes the donor hepatectomy. It's important that After the retrieval, you check the remnant for bile leaks, hemostasis, and if possible, you can do a laparoscopic ultrasound for the vasculature. Thank you.
So, thank you, Dr. Tiyagraj, for such nice demonstration of almost complete robotic donor hepatectomy. So actually, do you overshoe the end of the bile duct and the portal vein, or just apply clips or leave it?
No, you suture them.
You suture them. Use
Portal vein you don't have to, but bile ducts you oversew.
bile ducts you overshoe.
Portal vein stapler is enough.
So, do you ever use, like you told in laparoscopic donor hepatectomy, you do a midline incision. Do you ever use a small midline incision
10,
to
12
complete the
centimeters.
surgery and retrieve it
Yeah,
instead of doing a Fannel steal?
yeah.
You do sometimes?
Yeah, I do a lot of times. I use a short midline incision to retrieve the graft. It lessens the cold ischemia, warm ischemia time.
Warm ischemia time. That's right. So, if there is any comment from the audience regarding the videos you presented. Yeah, please.
Thank you. I'm Dr. Sindhu from Cotton Medical College, Kerala. Can you just help us with how do you retract this graft lever when you do the posterior mobilization of right lobe effectively without damaging the graft? How do you lift up and retract the right lobe?
In laparoscopic, you can use a gold finger covered up with a gauze piece. You can tie it. It curves and it can give you a good retraction. Or any, you can use a two grasper technique with two crisscrossing the assistants can hold. Or with experience, even with a traumatic bowel graspers, you don't address the posterior most port when you are mobilizing. You leave it for the last. Once you remove the right hepatic vein, it is very easily doable. You don't have to do the complete thing before itself. You can leave it to the last.
Okay, thank you.
I'm sure there will be a lot of questions also even after that when we finish off the lab and others. We can address that. If there is a second presenter who is already there, we can start off because
Thank you.
this is a donor nephrectomy and we can go ahead with later after standard lab resections of other diseases also.